Hi, everyone. Thank you so much for joining us today. We're so glad that you're able to listen in today as to what we know is going to be a very informative conversation from a very compassionate team that we all love. For those of you who do not know me, first, I just want to introduce myself. My name is Carmen David. I am a complicated type B aortic dissection survivor that happened 22 hours after I delivered my daughter. And since I have been a fierce advocate for our aortic community, basically since I dissected 8 years ago. I initially started off by founding Run for Aortic Health, which is a walk run event held in Fort Worth, Texas, that donates funds generated back to aortic research and initiatives that are important to our aortic community. So I'm really excited because it's actually coming up this coming Sunday, and it's going to be another great year of raising funds for all these projects that are so important to our community. Aside from that, I am an ambassador for Aortic Hope, an aorta advocate with the John Ritter Foundation. Am on the board for the Aortic Dissection Collaborative. And I started a support group for the pregnancy-related patients as well. And then most recently have joined Jack as an administrator for the Aortic Athletes Group, which is growing, and we are so glad that it is. And that was because it was such an important part of my own journey as well, and motivating people to keep moving and exercise, and that it is important that we can live, a long life still, and that we need to do that, and just have hope that we can, and it's safe. And so with that, today we are here with our favorite cardiologist, Dr. Siddharth Prakash from UT Physicians Clinic in Houston, Texas, and his research coordinator, Kayla House. So if you guys can say hello to everybody and introduce yourselves, your title, and your passion for this exercise and study.
Thank you so much, Carmen, and thanks to the Aorta athletes for this great opportunity. We can't state enough how much this means to us because we know how much it means to you all as our patients. For the last 12 years, I've been the cardiologist in our multidisciplinary aortic and vascular disease clinic here at UTHealth Houston. I also serve on the professional advisory boards of the Montalcino Aortic Consortium, the John Ritter Foundation, and the Turner Syndrome Society of the United States, where I advocate for patients and families with various forms of aortic disease. I do research, and my initial research interest was in the genetics of aortopathies. I do have a research study where we enroll patients to determine genetic causes, particularly of bicuspid aortic valve and aneurysms, but more broadly in any form of aortic disease. And more recently, I've become involved as an advocate for activity and exercise after my patients came to me in clinic with these questions about what is safe and what is acceptable or even beneficial. I realized there were no easy answers because there were no guidelines. And since then, I've made it my mission to improve the guidelines for all clinicians to provide consistent advice to patients with these kinds of questions. So thank you very much for the opportunity. Kayla?
Hi, my name is Kayla. I am a research coordinator on the clinical trial. I help to recruit participants like you guys, and then I also help to enroll participants in our clinical trial, and I am so grateful to be here.
Oh, Carmen, we just lost your mic.
Oh, I'm sorry. Can you hear me now? Thank you guys so much for being here with us today and taking the time out of your busy schedules to be here. We know that takes time to squeeze us in there, but we all very much appreciate it. I know everyone is always so excited, Dr. Prakash, to hear from you, and appreciate more than you know you're taking the time for us. And so thank you guys for being here. As far as our schedule today, Dr. Prakash is going to go ahead and give us an update on this clinical trial. And then Kayla and I will go to pre-submitted questions that we all know everyone's eager to get answered, and we'll get to as many as possible. And then Josh will chime in with our live chat questions from the audience that's listening in. You'll hear his voice in the background here shortly. So Dr. Prakash, you did say that, in the past that your number one topic of questions did come to you for what we can do, what can I not do? And it's just a constant question that you have come up in your practice. So can you just say again, just dive into explaining, you kind of already explained what led you to this work, but more about what this study is and really the importance of this clinical trial and the participation of patients in moving that needle forward, that we can have better advice and more scientific based advice, and just kind of what the study entails.
Of course. The journey to this trial started about 5 years ago. As I mentioned, I've worked in the clinic for many years. I've been receiving these questions and really frustrated at not being able to give our patients better advice. So I started asking if we could do a study to find out if it's, first of all, safe for people with dissections to exercise, and then to determine the quantities that might be acceptable or even beneficial. When I approached our institutional review board, the body that determines the safety of clinical studies, they said, "Oh no, you can't randomize patients with aortic dissections. That's too dangerous. As far as we know, there's no evidence that it's even safe to do that." And so I proposed initially to do a study of why don't we just observe patients, some with dissection, some without, and determine how safe it is for them to do some basic exercises. So we designed a circuit in our clinic, and we invited patients in our clinic who volunteered to go through the exercises while we measured their blood pressure and we determined the safety. This took about a year. We published those findings, and we found that overall, our patients, the first 50 that we did very well. They were able to complete all the exercises. We didn't have anyone develop chest pain, any new problems, and the exercises seemed to be safe and effective for the patients. After that, in 2022, is when we developed a proposal to actually develop a clinical trial. And the difference between the clinical trial and an observational study is that you actually randomize participants. The reason why this is important is that there are a lot of observational or anecdotal studies about exercise, but if they're not in a proper randomized controlled format, it's difficult to tell if exercise as an intervention is safe or effective, because in effect, you can pick the patients that you think will do well, you can make it look better than it actually is, or you can make it look worse than it actually is. And it's really hard to tell what is truly beneficial. So we wanted to do the first randomized controlled trial of exercise as a therapy for aortic dissections. And that required that preliminary evidence that it was safe, first of all. With that, we were able to go to the board of the John Ritter Foundation and say, look, we have this evidence, we have clear demand from our patients for more information about the safety and beneficial effects of exercise. Can you now authorize this trial? And the scientific advisory board agreed at that point. Fortunately, we were funded to do this trial back in 2022, carrying out over 18 months to be completed next year. And we're currently towards the end of enrollment. I think Kayla might be able to fill us in a little bit more about where we are in terms of enrollment and what we expect to do. But the initial goal was to enroll a total of around 130 patients. Half of them would be randomized to a guided exercise arm where we observe them in clinic and then counsel them about their exercise over 12 months. And the other half would be counseled about exercise, but not given any specific direction or training in exercise. So Kayla, can you fill us in about where we are in terms of the enrollment?
Yes, we have currently enrolled 86 participants across our 3 study sites in our clinical trial.
Awesome. So we still need quite a few more people then, huh? Well, I'm so excited about this study because I know I participated in the observational study back in 2021, and I have been a huge promoter of this because I know how important firsthand how it is when people have an aortic dissection and they go through this time of fear and depression and not knowing what to do. And then on the other token, getting back to exercise and really finding myself again. And doing the study was a real jumpstart to getting back to exercise and just kind of confirming that I'm going to be okay. Like this is fine to do. And then understanding what exercises were maybe raising my blood pressure too much or what other exercises were good. So I hope that people are able to get that kind of feedback from the from this study and, whenever it's completed as well.
Yes, and I wanted to speak to that a little bit because as we mentioned, this is the first trial of its kind. And anytime you're the first to do something, the bar is a little higher. And that's why we really do insist upon observing everyone who participates in the trial doing the guided exercises and so that we can, one, give them feedback that is personalized and directed towards their exercise technique and blood pressure. And two is to just ensure the safety of everyone, because that is clearly our number one priority, is to show that this can be a safe and effective form of what we think is therapy for aortic disease, because we do believe that eventually we will be able to show that this can actually improve outcomes in aortic disease. We're not there yet, but the goal in the next stage of this is to broaden the enrollment and look longer term to see if people who do engage in regular guided exercise activities do have better outcomes, fewer needs for aortic surgery, slower growth of aneurysms, and so forth. And we really need to continue the momentum that we've built, because this is not the end of the story by any means. We think of this as a beginning to a much larger story where we can change the paradigm about how aortic disease is thought of and treated by clinicians all over the country.
Yes, thank you. And I'm so grateful for that, because I know a lot of times patients are there's like this lack of congruency across the board, what advice doctors are giving. And so I do find that this is going to be so important for our future affected patients. So Kayla, can you tell us a little bit more about how people can get enrolled? And I really encourage you all to jot down this information from Kayla and let's reach that 130 people to complete this goal, because again, this is something that's really important that is going to be ongoing. But if we can get this ball rolling, like he said, I think it'll be outstanding. So Kayla, go ahead and let them know how they can enroll.
Yeah, sure. Thank you, Carmen. So if you're interested in either learning more about our clinical trial or getting enrolled, you can contact our office at 713-500-5239. Also email us at exercisestudy@uth.tmc.edu. And we do have 3 study sites total in our clinical trial, one in Ann Arbor, Michigan, one in St. Louis, Missouri, and then of course ours, which is located in the Texas Medical Center in Houston, Texas. And so if you reach out to us via those 2 avenues, we can get you connected with our other study sites as well.
Awesome. Thank you so much, Kayla. So until we can make an appointment to get to this clinical trial and speak to our own cardiologist as well, I think we'll go ahead and try to segue to some questions. I know patients are always eager to ask about these exercise questions. And just remember, I do want to note that this is a general conversation. Dr. Prakash is our expert, but he is not our cardiologist. So as we always kind of pre-note, you do need to talk to your own cardiologist about whatever exercise program you want to begin or resume. But I know Dr. Prakash can answer quite a bit for us here today. So we'll just segue right into questions. Kayla, do you want to go ahead and get started with a few that you have on your list from our pre-submitted questions from our audience?
Absolutely. One person asked, many patients report medications such as beta blockers having an effect on fatigue and their ability to perform well during exercise. And in some cases, it noticeably suppresses heart rate during exercise. Their question is there a long-term benefit to taking low-dose beta blockers such as metoprolol after surgery? And on the other side, are there side effects to long-term use?
Great question. Many of our patients have taken beta blockers at one time or are currently taking beta blockers. This comes up frequently. Yes, beta blockers, like any medication, do have side effects. And it's important to note that in most cases, these are minor side effects that do not prevent people from taking them. However, I always counsel people that they may experience some degree of fatigue, especially when they start the beta blocker. And this can wear off over a period of around 3 weeks. We recommend starting at the lowest possible dose because of this. It's generally more tolerable. and many people will eventually be able to overcome this initial fatigue. If it does not resolve, we do have many options in terms of beta blocker therapies, more than we used to, and many of the newer options do seem to cause less fatigue. Typically, with some trial and error, we can usually find a beta blocker that works for almost anyone. Now, after surgery or after dissection, it is often extremely important to continue beta blockers, particularly if you have residual dissected aorta or an aneurysm somewhere in your aorta. The reason for this is we know in randomized controlled trials that beta blockers can reduce aortic enlargement rates or dilation rates of aneurysms and also prevent further dissection in people who have a susceptibility, either due to a previous dissection or a genetic mutation that runs in their family. Therefore, we frequently tell people that they need to take their beta blocker lifelong, even after surgery to repair the aorta. That is not true in all cases, however, and so if you do have questions, again, as Carmen said, I urge you to discuss this with your clinician. Did that answer everything? That was a complicated question.
Yes, a very long question. Yeah, that was excellent. And then someone else asked, do you recommend certain beta blockers over others to help these symptoms? What indicators should warrant someone asking their doctor to increase or decrease their dosage? Symptoms include dizzy spells when weight training or exercise, blood pressure randomly dropping to extreme lows, and then long distance running with very, very low blood pressure.
Yes, as I mentioned, everyone responds slightly differently to beta blockers. There are some genetic determinants of response, but different beta blockers can have quite variable effects. If someone has an adverse reaction to a beta blocker where they're getting a lot of lightheadedness or fatigue, we can often switch to another medication. There is no one beta blocker that I advocate over another. All seem to be equally effective. And in terms of the dose, we generally push the dose to what we consider to be the maximum tolerated. That is the highest dose at which people feel like they can function and exercise without undue limitation in terms of lightheadedness or fatigue. That will vary for everyone. So just because you know someone who's on 50 milligrams doesn't mean that you have to be on 50 milligrams. It varies with your size, age, sex, and your disease status in terms of things like your baseline blood pressure. All of those things mean that they're fairly unique criteria for how to adjust the beta blocker dose. And what works for one person won't necessarily work for another person. That is one of the things that we do in our clinic is we carefully evaluate everyone, and we try different things depending on how we observe their response. In terms of exercise, because this came up a couple times, yes, your heart rate will not increase to the same level, and because of that, you cannot use what are called the heart rate zones that people often refer to when they talk about moderate or high intensity exercise. That doesn't work for someone on a beta blocker. We have developed an alternative method to determine exercise intensity for people on beta blockers, and it's something that we use called the Borg scale, which is a scale of effort that you grade from 1 to 10, where 1 is minimal or no exercise, and 10 is the hardest exercise you can imagine doing. If you're in the 4 to 6 range on your internal scale, that is good enough as a marker for moderate intensity exercise. So that's what we tell our patients, because for each person, that's going to be a different intensity, but for the same person, that's kind of a consistent level that they can imagine over time.
Okay, awesome. Carmen, do you have any questions that you'd like to ask Dr. Prakash?
Well, I guess I kind of have just a follow-up to that with the Borg scale that you were just talking about. So that I know we do have some people who run or cycle, and their blood pressure is low because of the beta blocker, and then some of them might be in a functional zone with their medications, but because of long-term exercise are getting even lower. And so that would be something that would warrant them going to their doctor to talk about, so it's not too low as they progress in their athletic activities.
Yes, many people have been concerned, especially if they check their blood pressure at home due to low blood pressures, and they will ask if their blood pressure is too low. That answer is also variable depending on the individual. If someone can tolerate their blood pressure without lightheadedness, dizziness, or fatigue, as we said, then that blood pressure is often quite acceptable, even though their doctor might look at them and tell them that it's very low. We go more by symptoms than by an absolute number, because everyone is different in terms of their ability to tolerate a significant blood pressure, and that is very valuable if you're on medication, because your blood pressure will be low. And we tell people that the benefits of the medication also are not directly related to the blood pressure. It doesn't have to necessarily be a specific number, but because we know that the higher dose of medication has independent effects on the aorta beyond blood pressure alone.
Thank you very much. Right. Let me take a look here. We do have some questions that are, let's see here. Why do some cardiologists or surgeons give zero restrictions to people after aortic valve or aneurysm repair, and for others keep more vigorous restrictions than a person had even before surgery? For example, if people are allowed to go back to the gym and lifting certain weights, extreme weights, even over 200 pounds, what is the difference in giving the restrictions advice?
Yes, so in most cases, the restrictions are based on the belief about susceptibility to aortic dissection. If the risk is considered to be high, the restrictions tend to be increased. However, the inconsistency that you noted is also a product of the fact that there are no national guidelines about exercise after aortic dissection. In general, those that do exist tend to be rather restrictive in reducing the amount of weight that someone can lift to a specific number, like say 20 pounds, even though there's no evidence that a 20-pound weight is any safer than a 30 or 40-pound weight. Really, all of that came from someone's opinion 20 to 30 years ago, and it's never been validated. So for these reasons, aortic disease is complicated. No two individuals with aortic disease are exactly the same, and that there aren't any guidelines. It means that you're going to get a whole range of recommendations depending on who you are and which doctor you see. These things can be extremely complex for patients and very confusing because it can change over time. So that is the reason why we receive so many questions, I'm sure, at least in part on this topic.
Thank you. And you hit the nail on the head there, that things can change over time. I know for myself personally, that was something that I wasn't a weightlifter, but just as far as cardio goes, was trying to just figure it out because, like you said, there is no guidelines. And so I just had to slowly start and figure out how my body was responding, figure out how my CT scans were continually showing stable, but over time to really understand what was okay and how far was okay. And I would think that would be the same with even certain exercise. If you're or for like weights, if you're used to lifting 50 pounds, then slowly maybe get back towards that, not just jump the gun and go straight to 200 pounds of lifting again, right?
Yes, I think people get fixated on this absolute top number, and they lose sight of the fact that it is a moving target. So if you're starting and you're deconditioned or you've lost muscle mass because you haven't exercised in 2 years after dissection, that you're going to struggle no matter which threshold you aim for at the beginning. The key is to start low and gradually increase the amount that you do so that that effort will decrease at the same level over time as you become stronger and better conditioned and more confident. So it tends to feed on itself, and that is why we focus on the effort level as opposed to an absolute number, because for the same two different people, it doesn't make any sense to have the same weight restriction. For instance, a 250-pound man would have a very different intensity or effort level to lift the same weight as a 120-pound woman. So why have them restricted both to the same number? It never made sense to me. And in fact, there's no evidence for that.
All right. Kayla, I actually have a couple more questions. This is kind of on this topic before I kick it back to you. So I know some patients have asked about body weight. So it doesn't matter if it's hand weights or a bench bar or body weight. If you're, say, a 230-pound guy wanting to do pull-ups and dips and push-ups, it's still the same advice no matter what type of weight training you're doing?
Yes, it's to avoid the extremes of effort and straining. And again, if you're extremely well conditioned and strength trained, body weight exercises may be appropriate for you. You may be able to do them effortlessly. And that is something that people do develop over time. But if you've never done them and you start to do pull-ups, that could cause huge spike in your blood pressure, extreme pressure on your arteries. That would not be advisable. So again, it's a matter of starting at a level that you can maintain at a moderate intensity without straining. And that is something that's going to be different for every person. That's one of the reasons we want to observe people doing these exercises first. So because sometimes it's very apparent that they need to start at a lower level than what perhaps everyone might imagine they could do. You don't know until you really watch someone, and we can also give people feedback about what sort of things to pay attention to while they're exercised, to maybe say, well, I'm doing too much, I need to back off, because that's okay. And giving that signal that it's okay, that you're not failing or you're not, you are exactly where you need to be. That is really important for people to hear, because I think sometimes we have in our mind a different picture of what we might actually be capable of doing than is healthy for us. So it's good to have that independent voice sometimes.
All right, great. Thank you so much. Kayla, I'm gonna go ahead and kick it back to you.
Okay, awesome. I have questions about some really interesting exercises. So I'm curious as to what you're going to say, Dr. Prakash. One person asked, is scuba diving safe for aortic patients? And then secondarily, is skydiving safe for aortic patients?
Yeah, so there are two kind of questions about this. First is that there is no data. We haven't obviously done a lot of trials. We have some anecdotal evidence that people have done these things and nothing has happened. And two, the concern with scuba diving is if something did happen, how accessible you would be in an emergency. I think that comes up a lot with people. As far as I know, there's no data to show that either one of those activities is harmful. In a related one, people ask me about roller coasters all the time. So simply traveling through space quickly is not in and of itself a risk factor for aortic dissection. We assume that that your heart rate and blood pressure will go up, but of course it does it every time you have an intense emotion in daily life too, and we don't restrict those. So there's no evidence that these are harmful activities, and I tell people, go ahead and do it, but these are risky in and of themselves. There are a lot of other things that can go wrong besides an aortic dissection, probably more likely with skydiving, for instance. Now, in terms of scuba diving, I get asked that one a lot, and I've said before, I'd love to do a study of scuba divers. I think we could get a good group, and it would be interesting to know, what goes on hemodynamically with scuba diving. I don't think there's even any studies of that. So I can't speculate exactly what's going on. I would say that if you're regulating your breathing properly, there should be no question that this is, that this should be a relatively safe activity if you're doing it in a responsible fashion. Again, I think that a lot of these are based on the unknown, the fear of the unknown, which was what led to all these restrictions in the first place. And so my feeling is, let's get information. Let's have people share their stories who are brave enough to be the first ones to do this, and then we can improve the confidence to engage in these activities.
Very well said. Very well said. And then I have two other questions having to do with more interesting exercises. One participant asked, is rowing a safe cardio exercise for aortic patients? And then secondarily, is yoga or hot yoga safe for aortic patients? And with yoga and hot yoga, are there any movement restrictions or concerns?
Yeah, so we actually have several groups in our, or subgroups in our professional societies that do advocate for yoga and Pilates and related activities because they're actually really good for stress, anxiety, and flexibility. So a lot of people who have aortic problems also have joint problems, and that the joint problems more than the aortic problems are what restrict them from doing many types of exercise. Particularly weight-bearing exercise or exercises with large dynamic components where you're jumping or contact. So yoga and Pilates are great for those aspects, and there's no evidence that they are harmful. In terms of the restrictions, they would be very similar to what we would recommend with other forms of weight-bearing exercises. So you don't want to strain. If you feel pain or discomfort, obviously you need to back off. But in most cases, people are able to complete these exercises. It gives them a sense of confidence and well-being that is very important in daily life. And I encourage people to do that with a responsible guide so that when you start, you know exactly how to progress without straining yourself excessively. In rowing, I haven't actually gotten that question a lot. It's very intense, and in most cases, if you're rowing, you're going to want to carefully limit the rate and the endurance aspect because it can rapidly become a very intense exercise. If you haven't done it before, you're going to want to start very slowly and ramp up very gradually. Again, I think that it is probably acceptable for most people, but there are a few exceptions. One of those would be individuals with particular spinal or joint issues that might be exacerbated by rowing. And so again, I would recommend if you're starting any new exercise, particularly one that can be intense, check with your doctor, make sure that you're checked out in terms of your aortic disease, that you know it's stable, that you're on the right medications, that your blood pressure is controlled, and also any additional concerns like the ones I mentioned to make sure that there aren't any things that you need to be aware of before you start that could play a role in response to exercise in the future.
Okay, great. Carmen, I'll hand it off to you. Do you have any questions?
Yeah, so we can just jump right into just high interval intense training there. I know a lot of people talk about just that in general, aside from just rowing in particular, and how it gives, is it safe for us because it does create that spike in heart rate during the activity, but does it differ by case type? So if somebody has like a bicuspid aortic valve that has been repaired or an aneurysm that has been repaired versus someone who has a residual aortic dissection or abdominal aneurysm, I mean, what are they looking at as far as, I know I've done some exercises where I don't think it looks like it's going to be a lot. And then I start to do it and my heart starts palpitating so hard that I think, like straight to the unknown, like, what is it doing? Should I stop doing this? Is this considered HIIT training? And then I just kind of stop myself. So how do we gauge how to proceed there?
Yeah, so interval training causes vast fluctuations in heart rate and blood pressure, and those tend to be exacerbated in people with aortic disease anyway. One of the most common patterns that we see is rapid fluctuations in blood pressure over a 24-hour period. We frequently do ambulatory blood pressure monitoring, and this is a common issue. Both low and high blood pressures in the same person over 24 hours. Sometimes people say that they feel faint or lightheaded, and then at other times the blood pressure can increase quite unexpectedly. For those reasons, we don't recommend high intensity or interval training. because it does tend to amplify those differences. And we know that sudden changes are what we're trying to avoid, both because they can exacerbate underlying hypertension, which is often difficult to treat when you have such fluctuations, but also because those are precisely the kinds of fluctuations that we see with intense weight training. And those sudden fluctuations are believed to be what has triggered cases of aortic dissection with heavy weights. So we want to avoid situations that look, at least from a blood pressure perspective, similar to heavy weightlifting. That is the reason why we recommend graded, slow aerobic exercise where you reach and maintain a steady state, hold that for as long as you can endure, and gradually increase the intensity and length of the exercise to avoid those fluctuations. It is true that for people who have limited time, intensity is appealing because you can feel like you get the same workout in a shorter period, but that compression has its trade-offs. And so I would encourage everyone to try the more gradual, slow route rather than the high intensity route. In a future trial, we could definitely test that, but right now, as you said, that is the unknown. And that's not what we're testing in our clinical trial either.
All right, thank you so much. So it's about 10:35. I think we're going to go ahead and jump over to Josh and have him ask some of our live questions in the chat from the audience. Josh, are you ready?
Yes, ma'am. First off, let's say hi to Velda. Hi to Bill Schmitz. Hi to Elena. She signed in with Nina. She says, morning, everyone. Hi to Brenda Stewart. Hi to Oaktastic. Julian Meldrum comes in with our first question. Hi from London, England. I've had some contact with people running cardiac rehab programs. Sometimes these include people who have had aortic surgery. Will you be able to set a guidance for this?
Yeah, so frequently I work with cardiac rehab programs to guide exercise for people after aortic dissection or aortic surgery. In fact, I think that reputable rehab programs typically do reach out to cardiologists or the cardiothoracic surgeons and request guidance. It is that actually makes me feel reassured when they do that, because I feel like they do need to be aware of the complexity of the patients, and a team-based approach is definitely the best. If you're not sure, you should ask. And I welcome those kinds of collaborations. I wish that it was universal, but we know that not all of these programs are quite as responsible. And that is why, we work with our rehab folks for this clinical trial and also for our routine clinical testing of people after aortic dissection. Not everyone is as fortunate. And that access to good quality cardiac rehab really is a right of anyone with aortic disease. And it's something that we want to be reimbursed by insurance and paid for in the same way that any other aortic treatment is paid for. That is something that these clinical trials can support. And in the future, I hope to change that so that everyone has that opportunity.
Thank you, Doctor. Dean asks the question, is it safe for me to carry a 5-gallon container of water to my car and to my house? They weigh about 40 pounds.
This is great because it reinforces what we were talking about. So I don't know how big you are, but if you're a large person, then that could be fine. However, if you're small or if you have other muscular or skeletal problems, I might not advise that. Again, it really is an individual kind of decision, and it should be guided by people who are familiar with you and your medical history. Before, if I don't know you, I can't give an informed decision and I could end up harming you. So my advice is to seek guidance from people who know you best.
Thank you, Doctor. Excellent answer. Hello, Bert. And that chat catches us up with chat. Back to you, Carmen.
Oh, okay. Well, then I'll just jump in with this other question that you may have a similar answer for, but I just want to read it out. My aneurysm is stable at 4.5, no genetic markers found, medically managed with controlled BP. Am I safe to continue lifelong endurance training and marathons at 73 years old? I think, if I recall right, this lady has done this for decades, and so she just wanted to know if it feels like it would be safe for her still.
Well, she modeled a lot of important things there. So first of all, she said exactly that, she indicated that her aortic disease has been followed and that she knows the status of her aortic disease. So that is so important. And I want to emphasize that before you start training or before you ramp up activities, it is essential that you know the status of your aortic disease, have checked in with an expert, and are clear that it is stable. That you are on the right medication, and then your blood pressure is controlled. And she said all of those things. So that gives me more confidence when I hear that she is actually being followed and getting regular checkups. That makes a huge difference, regardless of what kind of activity that you do. In general, aerobic endurance training is relatively safe compared to other kinds of exercise we've been talking about because it avoids those sudden changes in blood pressure. It's easier to regulate. And if you're in good endurance condition, then it's relatively gentle compared to other forms of exercise on your cardiovascular system. So having said all that, again, I can't give her definitive advice because I don't know her, but those are all positive aspects of her case that I wanted to share and emphasize with everyone.
Okay, great. Thank you. Let me just take a look here real quick.
I have another question from chat.
Oh yeah, go ahead. Go ahead, Josh.
John Brenny. John, I'm currently in the exercise study control group. Will there be more opportunities for future studies?
Yes, definitely. As I mentioned, this is just what we think of as the beginning of a much larger study where we can expand the questions that we're asking. Right now, we are asking, is exercise safe? Can it improve your mood, your anxiety, your confidence to engage in activities, and your blood pressure? All of those are important questions, but of course, what we really want to know is in the long term, does it keep you from needing to have surgery or other kinds of life-threatening complications related to aortic disease? We think so, but we need to follow larger groups of people for longer periods of time to answer those questions. So the next phase that we plan would be to get all the folks who have helped us so far, and we are so grateful to you, to participate in a larger and bigger trial where we'll have more resources to answer these kinds of questions. So definitely, you can expect to hear from us if you participated or if you even thought about participating. We are not done by any means.
Wonderful.
Okay, we have another one from chat here. Brenda says, my son has never done gym activity. I've requested he doesn't do any contact sport. His aortic dilation is 38 millimeters as of May 2023. Thoughts or comments?
Well, I'm not sure what the question is. If she's asking if it's okay for him to do specific kinds of activities, I would say, again, that really depends on the changes in his aortic condition over time, not just one particular time, but is it actually enlarging? Is it changing in any way? Is he on blood pressure medications? All of those things would have a huge effect on the likelihood of future change and the risk related to exercise, and should be addressed before starting any exercise program, even non-contact. So my feeling is getting regular follow-up, asking your clinician these questions quite specifically related to the type of exercise you want to do would be extremely important as the next step.
Thank you, doctor. Back to you, Carmen.
Okay. Well, just to follow up with that, I know that we do have a lot of patients who do ask these more specific questions that we know you can't fully answer for them, but just to touch base of it, some people ask about boating or water skiing and snowboarding, Brazilian jiu-jitsu and MMA type activities, ice hockey, even if it's, youth. I mean, youth can get pretty aggressive on the ice as well. So it doesn't necessarily have to be a professional status that they're holding, but I think the fear is the unknown of that impact. And is that why maybe sometimes doctors are more apt to tell you not to participate in those activities because they think something is going to happen just because of that impact in those particular sports?
I think the key here is the distinction between recreational and competitive. So in many cases, a sport can be done at a recreational intensity and is very different from that same sport at a competitive intensity. And many team sports fall into that category: basketball, hockey, soccer, things like that. If you're training and doing intense sports, that is on a different level than someone who does casual recreational activities, even if they're organized sports. So again, my question would be, what exactly is your goal? And then based on your current aortic disease status, your blood pressure, your medications, and all of that, what would be an appropriate goal that would keep safety foremost, but would still allow you to experience the benefits of exercise? And let's make a compromise that meets as close as possible both goals, but we have to keep both in mind, and that's how I would explain it. I think there are clearer guidelines for youth sports participation that we're starting to see coming out of some of the clinical work with Marfan syndrome, which I've been a part of over the past couple of years. And certainly there are checklists and other guidance for a lot of non-expert clinicians to use for youth sports that do go over a lot of these kinds of issues. I think we're not quite there yet, but there's a greater understanding about these trade-offs and the ability to discuss it and make an informed decision with patients and families.
So in making their informed decisions, we keep stressing the point that people need to talk to their cardiovascular surgeon or their cardiologist to go over these exercise activities they want to do, but what else can they ask? Do they need to ask specifically about a stress test, about cardio rehab, and obviously just be very open and willing to ask every question. I know sometimes people are afraid to ask certain questions or don't really know, or maybe there are time constraints within a clinic, but what is it that they need to do to figure this out so that they can go and begin their activity journey?
Yeah, so there is no clear guidance for people to know that they are quote unquote ready to do an activity. And therefore, we recommend a couple things. The first is to document the activities that you're doing so you can clearly communicate that to your clinician. The second is to make sure that all aspects of your aortic disease are well investigated. That means, do you know that you have an aneurysm or not? Is your aneurysm stable or getting bigger? Do you know that you have any part of your aorta that is dissected or not? If it is that part been changing at all? And how frequently are you supposed to look at it? So those are things that you should be able to ask and have answered at any of your visits with your aortic specialist. The third regards blood pressure. Now, in many cases, we use ambulatory blood pressures. This is somewhat new in the field, but we think it gives us a better snapshot of how people are dealing with blood pressure in their daily lives than a single office blood pressure. There are other ways to do this. You can check your blood pressure at home, but the key is to know what your blood pressure is doing, particularly if you've been told it's been high in the past. You want to make sure that your blood pressure is well controlled before you start an exercise program. Sometimes that takes a little bit of work. Maybe you go to the doctor and your blood pressure looks great, but you go home and your blood pressure is much higher. Maybe it's your environment, maybe something else is going on, but you need to figure out why that is before you would then ramp up your activities. So a lot of times there's preparatory work that you and your doctor have to do together, and understanding what it is, having a good common understanding and goal, where do I want to get to, what do I need to do, is a good topic for discussion at a visit.
Great, thank you so much. Kayla, do you have any questions in mind, or maybe we can jump to the therapies type questions?
I think it would be great to jump to the therapy type questions.
Oh, before we make that switch, I do have one more from chat here.
Sure, go ahead, Josh.
Bert asks, once on beta blockers, is it a lifetime med or can you get off of them in time?
Yes, we touched on this before in regards to surgery. In many cases, people can have a reduced dose of beta blockers or changes after surgery for a variety of reasons. Your blood pressure can change, the status of your aortic disease can change. But in general, we tell people when they start a beta blocker due to aortic disease that they should expect to be on it for life. The reason is that even though your aorta may change, the risks never go away 100%. And we know that beta blockers are relatively safe and they're the most effective medication we have to prevent future risk to the aorta, even if there's nothing visible presently. That is why we encourage people to stay on them.
All right, thank you. Kayla, do you want to ask the questions about the therapies?
Sure, yeah. I really find these questions about polar plunges and ice baths really interesting. So I guess I'll start with those. So someone had a question about ice baths. They stated that ice baths are another touted recovery tool for athletes, as we all know. Generally, temperatures can range from 38 degrees Fahrenheit to 52 degrees Fahrenheit. Is an ice bath safe for aortic patients? And what temperature is too cold for an ice bath or a polar plunge? Please explain, including what happens to the vasculature, and if there is a difference in an answer based on the category of patient. And I think you kind of touched on this a little bit, Dr. Prakash, knowing the specifics of each patient, but is there a difference based on the category of patients? For example, if they've had an aortic dissection, an aneurysm, they have BAV, or if their dissection is repaired or unrepaired?
So this relates to an interesting phenomenon that we have known about for 2 decades, which is that there is a seasonal trend in aortic dissections that is quite pronounced, where dissections seem to happen much more frequently in winter months than in summer months. And this has been speculated. We see this throughout the world, that there's a spike, a seasonal spike in dissections during the middle of winter. And it's also actually true for other kinds of vascular problems like heart attacks. So we don't exactly understand why, but the theory is that exposure to extreme cold causes changes in the vasculature that ramp up blood pressure. And that by itself can trigger acute events like heart attacks or dissections. The theory has never actually been worked out as far as I know, in animal models or anything like that. But we do know that individuals who are exposed to cold undergo a shift in their blood pool away from the skin and into the central vessels. This sudden dilation of the aorta might be what triggers it. In spite of that, there aren't any really active restrictions on exposure to cold weather. I always say that the key is to moderate your exposure. If you are intentionally exposing yourself, that might be a step too far for somebody who has had recent changes in their aorta, like surviving a dissection. I wouldn't advocate for that. But as you said, there are other situations where people might be fine doing that, as they don't have any immediate aortic risk. I do think there is a risk there, but it's hard to quantitate in general. We would have to go on a case-by-case basis.
Okay. And as a follow-up for that question, is there a difference in answers for doing hip down, chest down, or spot ice baths?
So no, exposure of any part of your body triggers the same reaction throughout your body because it's nerve mediated. So even, for example, there's a form of treatment for abnormal heart rhythms where we put cold on the hands and it affects the heart function. And so it is really nerve mediated, and any part of the body that's exposed for a significant period of time can trigger the same response.
Okay, and then my last question, switching gears to the opposite end of the spectrum now, are hot tubs safe to use? If you can, explain the temperatures and the time limit and what happens to the vasculature in this case.
Yeah, so when you're exposed to heat, obviously the blood vessels close to the skin dilate to relieve the heat, you know, whether that's through sweat or just through radiation of the heat through the skin. And that leads to decreased amounts of blood in the central part of the body, like the aorta. So it's kind of the opposite of what I was talking about for cold. That generally leads to a drop in blood pressure. And we think that's much less of a factor in terms of an acute problem than exposure to cold. Again, dissections drop during the summer, so that would be part of the same general theory. However, as we know, people can dissect at any time of the year, so that general rule doesn't apply to individuals. And if you have, for instance, already dangerous fluctuations in your blood pressure where you're getting lightheaded, going into a hot tub would not be advisable because you could pass out if you're on a lot of blood pressure medication. So I always tell people that they need to pay attention to their symptoms. If you have, you know, a reason to be concerned, then you need to take it easy with those changes in body temperature, because that's another stress that your body has to deal with.
Okay, awesome. Carmen, in the last moments of this Q&A, do you have any questions you'd like to throw out there?
Sorry, I guess one of my last questions is just what is the best biometric measurement that you can give a patient to make them feel more comfortable and just getting started and going, whether that's just breathing through, making sure that they're not straining, being able to talk, those sorts of things.
Yeah, so what I tell people in general about moderate intensity exercise is that you should be able to carry on a conversation while you're doing the activity, that you don't feel that there's a lot of straining in your chest or abdomen if it involves, you know, resistance, and that you don't feel like you can't continue, that you're not going to the point of exhaustion where you can't do another repetition or you can't continue past a certain point, that you stop well before that you reach those things. As long as you adhere to those principles and mind, you know, the level of effort using something like a Borg scale, most people can maintain kind of a steady level where they feel comfortable. That's the key to when you start out. You don't want to push yourself too much until you have a chance to acclimate to the activity, feel more confident, and then you can gradually increase.
Okay, great. Thank you. Josh, did we have any last questions in the chat?
Well, I want to say hi to Felicia and then hi to Bruce and other Bruce. There's multiple Bruces in here. One of the Bruces asked, what about what feels like gas in the chest area?
If he's referring to during exercise or at rest, there are many reasons for that sensation, but I would say if it's a new sensation, then you need to tell your doctor and stop the exercise, because what feels like gas may not necessarily be gas. That can be a sign of stress in the blood vessels or in the heart. And we want to make sure that you're safe first. So any new sensations, even if you're not sure if it's coming from the aorta, I would take it seriously and have it checked out. That's part of those preparations that we talked about for doing exercise safely.
Thank you, doctor. And can I get that 1-800 number again, please?
Oh, for our clinical trial. Yes, to enroll or to learn more about our clinical trial, you can call our office phone at 713-500-5239. And when you contact us, we'll get you connected with our other study sites, not just the one in Houston where we're currently located.
And do we have the email? Do we upload that to the chat so that people can contact
Yes,
via
ma'am.
the email as well? Okay.
Yes. Ma'am.
Awesome. Well, it's about that time. I so appreciate you guys joining in with us today and answering all these questions. We did get to so many more questions today, which is amazing. So I hope that people are satisfied with those answers and your expertise. And just know that if your question was not answered, we will continue to have more Q&As so that we can keep our list going and keep answering all of these questions for you. And just be sure to, I really encourage you to enroll in this study. It is so important. And as you can see, it's, we have a lot of patients already involved in it. And it really does just give you a sense of relief that somebody is able to kind of guide you on what's okay, what's not okay based on your numbers. And then, of course, to follow that up with your own surgeon at home and continue to ask these questions so that you can keep moving forward, because we all know that mental health aspect of this and not moving is plays a huge factor in the impact of our lives after all of this. So please join us with this clinical trial and contact Kayla and Dr. Prakash. Thank you again so much for tuning in. Thank you for answering all our questions and joining us.
Thank you so much to everyone, and have a happy and healthy and active life.
Thank you. Thank you all. Have a good day.